Uh, Thank you very much, Jasmine, for that kind introduction. Thank you also to the Takeda people for inviting me to do this talk. And for those of you who have lasted the whole day, um, this talk will pale in comparison to the excellent plenaries given by Alison Holmes and Wang Linfa. Okay. Um, so I think this is the topic: unmet needs and challenges in CMV infection. And as you can see, if we talk about unmet needs, there's probably something that is going to try to meet this need. So my duty today is to go through some of the problems that we have been facing regarding the management of CMV over the past many years and set the stage for Professor Sasa Dues's talk. As such, I think for many of you, my talk will be a very simple revision. These are my disclosures, and this is the lecture outline. So what is the impact of CMV on transplant recipients? As we know, there are direct and indirect effects of CMV on the patient. The direct effects, we divide them into infection and disease, and so a few definitions are in order. Infection just refers to evidence of replication, regardless of symptoms. Disease we divide into two categories. So there's CMV syndrome, which is basically a mononucleosis type illness with fever and lethargy, some cytopenia, and either lymphadenopathy or very mild splenomegaly. Whereas end organ or tissue invasive disease refers to the pathology produced in individual organs by an interaction of the pathogen with the host immune response. So you're all familiar with things like retinitis and pneumonitis. The indirect effects of CMV, some are easier to prove than others. So there's long been talk that with CMV infection, the patient is predisposed to acute allograft rejection. Then these manifestations of chronic allograft failure have also been attributed to CMV, such as bronchiolitis obliterans in the lung recipient. And of course, for the longest time, there has been an association between CMV and atherosclerosis, including coronary artery disease after transplant. So the rates of CMV infection, we actually know for a long time. The D plus R minus recipient is at greatest risk. So I thought we might look at some of the more recent data, and the best data do come from the Royal Free. Unfortunately, the latest data is about 10 years old by now. So basically, they were just drawing blood from their renal and liver transplant recipients. They have long used the preemptive strategy, and they have this cutoff, this trigger for starting antiviral therapy. So basically, in the first 90 days, about 43% of patients developed viremia, and half of those required treatment. A very small percentage developed the first episode of CMV illness after the first 90 days. And then in terms of syndrome and end organ disease, actually the numbers and percentages are very small. It's also very interesting that this hierarchy of risk has been preserved over the years, and the D plus R minus population is at greatest risk of both viremia and the need for treatment, whereas the other categories are, well, you get it less frequently. Now, in the bone marrow transplant population, here are the CIB MTR data quite recently published. And basically, it's the reverse, right? It's the D minus R plus that is at greatest risk. And here you can see that it's about 32%. But actually, the R plus, any R plus is a risk, because you can see from the CIB MTR data that that category, 32% of them also develop some sort of CMV reactivation. Now, in terms of end organ disease, this is what we all fear, and we've all seen very, very difficult cases such as colitis with intractable hemorrhage. These are data from a long time ago, just to give you a flavor of what it was like in those days when there was no CMV prevention. So about a sixth of the patients in this series of kidney and kidney pancreas recipients actually developed tissue invasive CMV disease. And in those days, all had to be diagnosed by characteristic histopathology or viral culture. All were given IV ganciclovir. This was just in the early 1990s when IV ganciclovir just became available, and the cure rate was very, very high. But if you look at percentage survival after some time, you find that the group that had gotten end-organ CMV disease actually did better, did worse 3 years down the road. So the survival was poorer, and that was statistically significant. In the allo HSCT population, the data are the same. This is also from CIBMTR, also published quite recently. And you can see that no matter what the primary disease, whether it's AML or ALL or CML or MDS, reactivation increases non-relapse mortality. So basically CMV is bad, and that's why a lot of effort in academia and in pharma has been invested in anti-CMV management. So what are the standard approaches? Well, it actually consists of two that all of you are very familiar with. It's either prophylaxis or preemptive therapy. So prophylaxis is treatment that's given to prevent disease. So it's given to everybody. It's non-discriminatory. All transplant recipients would get it if you adopt a prophylactic strategy. Now, the preemptive mode of prescribing antimicrobials, this was mooted and popularized by Bob Rubin, under whom I had the pleasure of training. And he defined it as the mode in which antimicrobial agents are administered even before clinical infection occurs. And there's no universality to it. You must be able to identify a certain subgroup, and preemptive modes of prescribing antimicrobials are only possible with technological advances. And the advances in the mid-1990s were, of course, the ability to detect CMV quickly, either by the antigenemia assay or the PCR. So which is better? This is a direct comparison meta-analysis. And if you look at the endpoint of invasive CMV disease, then there appears to be no difference whether it was prophylaxis or preemptive. But in terms of late onset CMV disease, obviously there is more of it in the prophylaxis arm. And why is that so? I think this was proven, was demonstrated some time ago. These authors used CMV ELISpot assay, right? So they gave prophylaxis to all their D+ R- patients and preemptive therapy for all R+ patients. So that is quite a commonly adopted strategy, and we also use such a strategy in our units. So basically, you will see that in the preemptive arm, of course, there's some increase in antigenemia or in PCR. But at the same time, whereas in the prophylaxis arm, there would of course be zero antigenemia or PCR until very late. But if you look at the ELISpot assay, if you look at the anti-CMV specific T cells, you find that pre-transplant, of course, there's a lot of anti-CMV T cells. And then in the very early post-transplant period, of course, it comes down. That's the result of all the immunosuppression that's given to the patient. But very quickly, CMV and T cells against CMV recover, right? And that's because it's believed that in the preemptive approach, you are actually allowing some degree of CMV replication and that acts as a stimulus to your immune system. Whereas if you had prophylaxed very, very successfully and suppressed all the CMV, then your immune system would just have gone to sleep anyway. And it's only later when there is when you get the late onset CMV, then only will you mount response. So other people have also done another meta-analysis. This is more recent, trying to look at the direct comparison studies, right? So they found that the field was heterogeneous. There were 5 open label RCTs, 5 retrospective cohorts, and 1 prospective cohort design. Quite a lot of heterogeneity, as you can see here. All studies included CMV and organ disease as endpoints, but not all included the CMV syndrome. And the duration of follow-up was also very variable. So if you look at the endpoints, so there are different endpoints, of course. You find that in general, this paper, this meta-analysis found that prophylaxis did reduce the risk of end organ disease, but the NNT was variable from 13 to 79, accepting the moderate heterogeneity of about 39%. In terms of the ability to prevent biopsy-proven acute rejection, there was no difference. As you can see, the forest plot crosses the midline. So if we don't really have very good hard clinical outcomes to go by, then maybe we can look at money, right? Is it more cost effective? So this is one of several studies. This is from a single US center only. And they look at the difference between mean universal versus preemptive costs per patient. Now, I think just some details about this study. They look only at the R plus patients, and they had 2 different time periods. One when they employed universal prophylaxis, and another when they employed a preemptive strategy. And the truth was that when you resorted to the preemptive strategy, there are all these problems with adherence, right? So only 80% of the expected PCRs would be done, and the per patient compliance rate was 51%. And then this is where the cost difference is. So in terms of the cost of valganciclovir, it's of course much higher in the universal prophylaxis arm. Whereas in the preemptive arm, you're actually paying for the CMV PCR. So at the end of the day, it's really very hard to choose between the 2 strategies. There's not much to go in terms of hard clinical endpoints. And in terms of costs, you find that you're just paying for different things. Although you can see that if you take overall, if you take totals in the first row here, it's the preemptive strategy is slightly cheaper. Now, in the HSCT population, there is no prophylaxis, of course. As you can see from this major paper, which is quoted many, many times, this is one of the How I Do It papers in Blood. Most of the experts do the preemptive strategy, right? So these are, the authors are 2 very famous people from 2 very famous centers, one in the Karolinska and the other at Fred Hutch. And the reason is very simple. The available drugs that we have are toxic to the bone marrow transplant recipient, right? You wouldn't want to give ganciclovir to someone whose marrow is new, only starting to grow, and of course, foscarnet is nephrotoxic. So I think to all of us as ID physicians, the challenges that we face are very obvious, and they have to do with the toxicity of the drugs. So I shall at this stage share 2 of the more challenging cases that we have had over the years. This is a 42-year-old woman who was 5 years after a heart transplant. She's been stable all this while, but then she presents with effort dyspnea, and an endomyocardial biopsy proves the presence of rejection So she gets a pulse of methylprednisolone with good recovery. And of course, they don't just do that, right? They will probably increase the steroids and the cyclosporin. And because of that, whenever people have acute rejection with augmentation of immunosuppression, we have a protocol to put them on weekly PCRs. In other words, to restart the CMV clock in terms of preemptive monitoring. And so at some point, we discover that she is PCR positive, right? So it's actually, it starts off very low, 178 units, but soon it goes up, and therefore valganciclovir is started. If you look at her CCT, it's not very good. It's 45 mils per minute. With a creatinine that's above 100 micromoles. So we did try to load her with some Valgan for a few days and then put her on the dose recommended by the Sanford guide. And over just under a month, the CMV reactivation does come under control. But very soon, there appears to be a rebound. And so it's now almost 1,000 international units. So again, valganciclovir started. She remains very well. This is all in the outpatient setting. She's sent to the eye surgeon and there's no retinitis. She has no symptoms to suggest pneumonitis or colitis, and her LFTs are normal. But here, this time, you can see that in spite of valganciclovir, the CMV PCR is just racing upwards, right? So what shall we do at this point? I don't think there is a mechanism to vote, but obviously these are some of the options. We could admit her for IV ganciclovir, probably to improve bioavailability. We could admit her, give both IV ganciclovir and hyperimmune globulin. We could give IV foscarnet, of course, although it would have to be dose adjusted for her relatively poor renal function. We could also send for CMV resistance testing, or we could float an email on TID chat. So we chose to give her IV foscarnet. And as you can see, there were some very anxious moments when her creatinine rose, but we persisted and gradually the PCR came under control. So basically we were quite lucky, but maybe it wasn't that she had refractory or resistant CMV, because there is this phenomenon of a paradoxical rise in antigenemia or DNAemia. This was first demonstrated at the Fred Hutch, where they showed that even after you start ganciclovir, the antigen levels or the PCR levels will go up, but then it will come down if you persist. And when they did this multivariate analysis, receipt of high-dose steroids was the only risk factor that was associated with this paradoxical rise in antigenemia. This is a Korean paper showing the same thing, that you can also get this paradoxical thing with response when you persist with the same drug. And the Koreans had a slightly different set of risk factors for the paradoxical rise. They had low white cell count and the delay before commencement as the major independent risk factors. And they found that actually there was no difference in one-year mortality. So that's just a paradoxical rise. We have to distinguish that from the concept of refractory CMV, which was officially defined quite recently as a rise in CMV, DNAemia, or antigenemia after at least 2 weeks of appropriately dosed anti-CMV therapy. And the smaller print there is more for very big countries. So they say that there has to be at least a 1 log increase in the peak plasma viral load measured more than 2 weeks apart by the same lab, by the same assay. So it doesn't quite happen in Singapore because our patients come back to us, but in the big countries where you are transplanted in a major care center, major tertiary center, but go back to the small town, you may get CMV tests done in different labs employing different assays. So as you can see, this patient in whom we started foscarnet, her white cell count began to drift down as she had been on when she had been on Valgan, and her creatinine went up. So that's where I think the unmet need is. Ganciclovir is myelotoxic and foscarnet is nephrotoxic, something that we knew a long time ago, right? Because from this 200-day Valgan prophylaxis study, we already could see that the 200-day versus 100-day arm. The 200-day arm had more cases of leukopenia and neutropenia. And the nephrotoxicity of foscarnet was actually demonstrated a long time ago in this very early study of CMV retinitis in AIDS. And you find that the foscarnet arm had a greater rise in creatinine. Okay, so we come now to another patient. This is a renal transplant patient with resistant CMV. She's very young. It's 5 months post deceased donor renal transplant. She's D plus R minus, so she's put on Valgan prophylaxis. So actually, nothing very major. She is induced with basiliximab. There were no surgical complications. She had very immediate graft function, and she stayed for just 2 weeks or under. And the post-transplant recovery was also quite good. She had cyclosporin. By the time we saw her, it was already 125 BD, which wasn't very high. MMF less than a gram a day, and all the others, which were quite standard. Now, however, while she was on, but one day she had this rise in PP65. This is a case from some time ago. That's why it was a time when our unit was still using the antigenemia rather than the PCR. And so she was, the ganciclovir dose was bumped up to 900 twice a day, which is the full dose, right? And then as the PP65 antigen came down to 17, someone actually dropped the dose to 900. And with that, the antigenemia came up. And when we look back, I think one of the members of the primary team had done it because they had noticed a drop in the white cell count. Anyway, with an increase in dose, the antigen levels came down to negative, but only for a while, because after that it rebounded and with a vengeance, and it went very high to 131 copies, and we sent the blood for sequencing, and we were able to demonstrate the presence of UL97 mutations. So here we have ganciclovir resistant CMV in a renal transplant recipient. Yeah, so this is the official report from the lab. So basically, what was there? This was some time ago, 2010. As you can see, we started foscarnet, and fortunately, her creatinine clearance was not affected, and she managed to clear the antigenemia. But if you think about it, they also, of course, reduce MMF. You know, they reduce the cyclosporin, they reduce the prednisolone. You remember there was 28 milligrams a day in the beginning, and I think we got away with the skin of our teeth. So I think that's what I have tried to discuss would be standard approaches in the management of CMV in the solid organ transplant and bone marrow transplant population, and to share a few cases which were problematic but which fortunately had happy endings. Thank you.